We have the pleasure of having Professor Timothy Anderson, or I think Tim that he goes by, from Harvard to talk to us about inpatient hypertension. Tim did his med school at Case Western in Cleveland, where he also did a master's in bioethics, it seems. He went on to do internal medicine residency at Pittsburgh, and he also did a primary care fellowship, research fellowship at UCSF. Presently, of course, he's at the Beth Israel Medical Deaconess Center in the Division of General Medicine, and he's an assistant professor at Harvard. He's done, his research spans cardiovascular outcomes and pharmacoepi, but in particular for us, he's done a lot of research using, I guess, administrative database or electronic health medical records and hypertension. So today he'll be talking to us about elevated inpatient blood pressure to treat or to tolerate. Go ahead, Tim.
Great, thanks so much. It's a pleasure to be speaking with you all today. And this will be a new format for me with Teams because I can't see you, I can just see the screen, but feel free to interrupt if questions or other things come up. Just a disclosure slide, my research and some of the work we'll be talking about is supported by various nonprofits, but none by industry and by my own local institution. So just a very quick intro to me. So I'm a general internist. I now mostly do outpatient medicine, but most of my time is spent as a health services researcher where, really many of my questions are thinking about how do we use observational methods when we don't have clinical trial data that we'd like to have. And so taking advantage of clinical, administrative, and pharmacy data sets to try to answer questions that are clinically relevant. And I think this is a particularly nice case with inpatient hypertension, where as much as I would love for there to be perfect trials, I think the financial incentives and the need for very large multi-site trials just make that unlikely to happen anytime soon. But today we're just going to focus on inpatient hypertension. We've certainly applied some of these same principles to other common chronic diseases with a focus on older adults, given the complexities of multimorbidity in these populations. So I'm really going to talk today about inpatient blood pressure management and focus not on symptomatic hypertensive crises, for which I think there's lots of guidelines and you all probably know them quite a bit better than me in many cases, but instead on the much more common and much more kind of evidence-free zone of what to do with folks who simply have high blood pressures in the hospital. And what I really want to think about is some emerging observational evidence in these groups of patients, and then also kind of rethinking how we plan out transitional care for patients with hypertension who we see in the hospital when we're really thinking about something that's not an acute condition, but a long-term chronic disease to be managed. And so we'll kind of go through three sections, talking just a little bit of background about what we really mean when we say the phrase inpatient hypertension. And then two clinical questions, what's the evidence around whether we should acutely treat elevated blood pressures during hospitalization? And then I think the most interesting question of whether or not we should be viewing hospitalization as a time to adjust outpatient medicines, and particularly intensifying outpatient medicines. And so I always like to start just to set the scene with a clinical scenario. And so we'll use Mr. T, an 80-year-old man with hypertension who at home takes 10 milligrams of lisinopril, who's in the hospital for community-acquired pneumonia, or these days probably COVID, and COPD. And during his 5-day stay, his blood pressure gets measured 4 times a day, and it varies from the hundreds over 60s to the 170s over 90s. As a result, overnight, he gets IV hydralazine a couple times because his blood pressures were higher. And then the medicine team on morning rounds decides to, over the course of these 5 days, increase his lisinopril to 20 milligrams and then add amlodipine 5 milligrams. And they tell him when he's ready for discharge to continue these meds. This is the sort of thing when I was in training, I did a lot. And then when I was more in the primary care side, I would see the flip side of, and sometimes see folks who came out of the hospital quite overtreated and always kind of wondered, like, what should we be doing in these scenarios? Because it felt frequently like we were responding to numbers more than anything else. And so, what is a goal blood pressure is something I love to ask my med students and residents. And on the outpatient landscape, I mean, there's lots of evidence, and I know that this differs country to country, and the US is particularly aggressive when it comes to what we call normal or elevated. But we certainly have, gradations of risk, and I think we have a lot of observational data as well as even trial data around kind of risks and benefits when it comes to blood pressure management in the long-term setting. However, in the inpatient setting, we don't necessarily have those goalposts. We do know a couple different things. We know that we love to measure blood pressures in the inpatient setting. And I think, much of this is really driven by this idea of detecting hypotension, which of course is appropriate. We're looking for signs of bleeding, of sepsis, of other causes of kind of emergent conditions. But we also know that inpatient blood pressures fluctuate quite a bit. And this is obviously most related to acute illness, folks coming in hypotensive and gradually improving if they're recovering from certain things. It's certainly often due to measurement error, at least if your inpatient wards are anything like ours. I mean, I often watch patients have their blood pressure checked while they're having their blood drawn out of the same arm, much less kind of simpler issues when it comes to things like blood pressure cuff size and the like. And I think it's important to also think about things like new medication exposures. I mean, we're often using anti-inflammatory steroids and other things associated with blood pressure elevation, as well as hospital-related stressors. And I really like this figure from Dina Goldwater, who's an emergency medicine doc in UCLA, that kind of diagrams out just the various things that can contribute to kind of overwhelmed stress response while patients are in the hospital. And while this isn't hypertension specific, I think it certainly gets to this idea of kind of allostatic overload being one potential driver of fluctuations in blood pressure. And certainly, things like delirium as well are just as much part of this pathway. So, we don't have a goal in patient blood pressure, at least I've never seen an evidence-based case for one. We have our guideposts of if folks are running less than 100 systolic, we start to worry it's too low. If they're running greater than 180, maybe we're starting to think that that's probably too high. But we really don't have the same buckets to think whether a blood pressure of 120 or a blood pressure of 160 while someone's in the hospital is really better or worse. And despite that, I think we often pay attention to these numbers quite closely for hospitalized adults. One question is, what do these numbers mean? Do they really reflect outpatient blood pressure? And there's been a series of studies, some of them are getting older now, that have tried to ask, just what are the reflections of blood pressures on the inpatient setting? There was this systematic review that's getting about 10 years old now that looked at a couple single center studies, and they found that inpatient elevations in blood pressure are exceedingly common. I mean, more than half of patients, maybe even 3/4. And this is true whether you use regular clinically obtained routine blood pressure cuff recordings. It's true if you use more advanced 24-hour blood pressure monitoring or kind of like ABPM sorts of studies on inpatients. But most of these older studies really haven't compared inpatient blood pressures to outpatient blood pressures. So we don't know, is this just the fact that hypertension is common and so people run high in the hospital and high at home? There's this nice Swiss study that's a couple years old. It's small, but they actually did 24-hour ambulatory blood pressure monitoring in folks over the age of 80 who were in the hospital. And so they took 31 folks, they did an ABPM while folks were hospitalized, and then they did an ABPM 2 weeks after they went home. Didn't do anything to the patients beyond measure their blood pressure. And what they found, which I think is somewhat telling, is that they, as a group, had a significant drop in their blood pressure upon returning home, a mean change of about 7 millimeters systolic, a little bit less diastolic. But they also found that nearly 2/3 of these patients, even the ones who were running high, were orthostatic during hospitalization, which clinically fits a picture of many of our patients are either deconditioned or often dehydrated and the like. But suggesting that simply leaving the hospital is a good treatment for blood pressure in some ways. Our own group has contributed a little bit of this literature, and I'm going to talk more about this study later on in terms of its clinical outcomes. But we've, again, just tried to ask how much do inpatient and outpatient blood pressures correlate. And we've focused our efforts in the Veterans Affairs health system in the US. So unlike many other wiser countries, the US's healthcare system is so I guess, scattered, that it's often hard to track patients between inpatient and outpatient settings because often the EHRs don't communicate. We don't necessarily have government registries. But one exception to that is our VA system for folks who served in military forces. And the VA system is a large 130 hospital system scattered all across the US that takes care of multiple millions of patients. And so it's a nice place to think about these sorts of questions. But everything I talk about with the VA is tainted by the fact that it really serves a predominantly male population, and it also serves a much kind of more multi-morbid population than perhaps the average US population. These are vets who have a higher burden of substance use, a higher burden of depression, a higher burden of chronic conditions. That being said, it's often the best we can do. So we looked at about 15,000 older adults who had hypertension diagnosed in the past, who were in the hospital for other conditions, so things like pneumonia. And about a third of them had high blood pressure at home, just looking at their outpatient records. In the hospital, about a quarter of patients overall had high blood pressures. And it makes sense that this is a little bit lower because, again, these are folks coming in the hospital often for conditions that might make you hypotensive. And unsurprisingly, having high blood pressure was more common amongst patients while hospitalized if they had chronically elevated blood pressure. That being said, nearly half of patients with high blood pressures in the inpatient setting, and when I say high, I'm talking about blood pressures in the 160s, 170s and above, nearly half of them actually were normotensive before admission, telling us that trying to kind of make outpatient decisions based solely on an inpatient blood pressure recording can be pretty misleading. Since you really can't necessarily tell, it's almost a coin flip whether these patients were high or normotensive at home. And at least in the US healthcare system, this becomes an even more vexing clinical challenge because in the VA, you're able to look at outpatient records. In the hospital I work in, I don't know the outpatient records for most of the patients in the hospital. I only know them for patients who also get their primary care at Beth Israel. But for folks who get primary care in private practice or in other health systems, we're kind of operating in the dark unless the patient happens to know their home blood pressures, which is relatively rare. So, when we talk about inpatient hypertension, I think it's important to recognize that we go on and on about it and often tell our trainees to do this and that, but we really don't know what an ideal blood pressure is. We are starting to realize that inpatient recordings aren't a great marker of outpatient blood pressures. And this has led some folks, including one of my colleagues at Oregon Health and Sciences, to really argue that these concepts like hypertensive urgency are really a harmful misnomer. And we really shouldn't always be using the word hypertension to describe what may be an acute elevation that may not actually be a long-term marker of problems. So, with that background, I want to move into thinking about what we should do when we see these patients with high blood pressure, because this is something obviously with full hospitals, both in Ontario and in Massachusetts, that many patients are obviously not coming in with, but that our clinical teams are making treatment decisions about every single morning. And I'm not going to focus on symptomatic hypertension, like I mentioned. There's many good guidelines that I think are much more evidence-based about what to do with folks who are truly having syndromic problems related to elevated blood pressure, like acute coronary syndromes and strokes and other things. I'm really going to focus on folks whose blood pressure is asymptomatically elevated. And so, I actually looked at Hypertension Canada to see if you all had better guidelines than we do. But in our 150-page set of hypertension guidelines that came out in 2017, there's actually 0 pages devoted to this clinical scenario to talk about what do we do with inpatients with high blood pressure. There's obviously lots of text spent on what to do with folks in the hospital for a stroke, in the hospital for a heart attack. But we really are in a guideline-free zone. And so I think as a result, what often happens is that we apply outpatient guidelines to the inpatient setting. In the absence of evidence, we use the next best thing, which is evidence for a different scenario altogether. And I think observational data kind of backs up this hypothesis. So multiple single center studies suggest that we do a lot of single dose PRN antihypertensive treatments. And this includes both pills, but often IV treatments. And at least in the US, hydralazine and labetalol are particularly commonly used. There's a nice study from hospital medicine colleagues at UCSF a couple years back that looked at, again, patients in the hospital for non-cardiovascular conditions, they found about 10% of their population had elevated blood pressures over the 160s that got IV medications. They were pretty convinced this was not good care, and so they did a really nice multi-pronged quality improvement initiative that focused not just on physicians, but it focused on nursing and it focused on things like hospital alarms to try to reduce the use of IV medicines, not necessarily treating, but at least treating intravenously, and managed to cut the use of IV meds from 11% down to 7%. They didn't really do this as a research study, more as a quality improvement initiative, but they did track things like ICU transfers and rapid response codes and found no change, suggesting that this switch was something that could be done safely and effectively, and also something that persisted beyond kind of the initial intervention, at least for the subsequent 6 months of follow-up. Other studies have suggested that IV blood pressure treatment risks overcorrection, and so there's a handful of these papers that do this, but there's kind of sets of studies that look at folks who got an IV blood pressure medicine and then ask what happened to their blood pressure immediately thereafter. And this case series at Detroit of 172 patients suggests that you really get really large swings in blood pressure with hydralazine and labetalol given IV. So 17 millimeter decrease with hydralazine on average. And I think the important piece here is that about a third of patients actually had a blood pressure reduction greater than 25% within 6 hours. And I bring that up because so often when we think about management of hypertensive emergencies like stroke, we really talk about being cautious with blood pressure lowering. And yet when we think about using intravenous treatments for asymptomatic patients, we're actually much more cavalier. And we don't really know if that could risk harms in terms of overcorrection, whether it's renal-related harms or whether it's harms in terms of cerebral hyperperfusion. There's certainly older data about certain types of IV calcium channel blockers that we don't use anymore with this risk. But this hasn't really been studied in terms of, if you suddenly drop somebody too low, are we doing more harm than good? Until recently, there really weren't studies of acute blood pressure treatment. We had some observational data, mainly from emergency room settings. And these studies would usually be structured like this one that I'm highlighting from the Cleveland Clinic at, patient comes into the clinic with a blood pressure of 180. Some primary care doctors are going to send them to the emergency room and some primary care doctors are not. And they took advantage of this treatment heterogeneity to ask, does it actually help to send these folks to the emergency room? And in general, in these Cleveland Clinic studies, they found that major adverse cardiovascular events in the real short term, like the next 2 weeks or next month, are exceedingly rare. And that sending folks to the ER and when folks are hospitalized for hypertensive urgency really doesn't improve outcomes, whether it's cardiovascular events or downstream blood pressure. Obviously, there's some importance in ruling out an emergency and doing the correct clinical workup to make sure that someone with a blood pressure of 200 isn't truly having symptoms. But if that can be done safely in the outpatient setting, these have suggested that hospitalizing people is not necessarily beneficial. Hospitalized patients are a bit different than patients in the clinical setting, but I think this still, provides this treatment rationale that when we're thinking about why are we doing this, really our goal in acutely treating inpatient blood pressures is to reduce an immediate risk of harm. So something that's going to happen in the next couple of days. And so we haven't had trial data in this space whatsoever, and until recently, minimal observational data. The same team at the Cleveland Clinic, led by Michael Rothberg, who's an internist and health services researcher, has published a nice study that asks about outcomes of inpatient hypertension treatment. And I'm going to talk about it, critique it, and then talk about what we're doing to try to address some of the critiques of this study. So they looked at about 17,000 adults who had high blood pressure while they were in the hospital for other conditions. This was in the Cleveland Clinic health system, which is not just in Cleveland. They have campuses in Florida and other places. It's a fairly large health system in the US. And they used propensity score matching to ask, what are the difference in terms of important inpatient outcomes like acute kidney injury, troponin elevation, or stroke amongst patients who had high blood pressure and were treated versus patients who had high blood pressure and were not treated. there was a little bit of wonkiness to how they defined this. So they looked at a hospitalization and they picked the very highest blood pressure that one person might have. And then they defined treatment as whether or not that highest index blood pressure was treated. We'll get to how this might be a little problematic, but what this means is maybe somebody on day 2 of hospitalization had a blood pressure of 170 and got IV hydralazine, and another patient on day 5 of hospitalization had a blood pressure of 170 and did not get IV hydralazine. And then they asked what happened to folks following treatment. They had pretty nice clinical data. They were able to account for a lot of things in their propensity score structure, including not only demographics and comorbidities, but information about patients' blood pressure characteristics prior to being kind of treated, as well as in the outpatient setting in many cases, as well as other information about why patients were in the hospital. And so they ended up with about 4,500 patients in each arm of their matched analysis, and it was a well-balanced study. What they found was about a third of patients received new or IV blood pressure medicines. They didn't include loop diuretics to avoid kind of miscapturing heart failure treatment and the like. But they also found nearly 9% of folks received IV antihypertensives. Sorry. And just to cut to the punchline with the study, what they found was that there was no benefit and even perhaps a suggestion of possible harm from treating the highest inpatient blood pressure that patients had. And they present a series of odds ratios. I'm just showing you the composite outcome where they grouped acute kidney injury, troponin elevation, and stroke. And consistently, regardless of treatment route, whether patients were being treated with IV or oral medications, and regardless of the level of blood pressure that was treated, whether it was truly severely high, like in the 180s, 190s, or whether it was only modestly elevated, they found that there was actually worse outcomes, meaning more acute kidney injury, more troponin elevation, and stroke amongst patients who received blood pressure treatment. And this was really actually driven mostly by a higher rate of acute kidney injury amongst the patients who received antihypertensive therapy. So there's certainly limitations to this. Propensity scores are both one of the more commonly used advanced observational research techniques that attempt to control and balance patient characteristics, much like we would aim for in a clinical trial with randomization. But these models can only control for what we can measure, and so there's always a concern of residual confounding. What I think is perhaps more directly relevant in this study is that a good number of their patients had atrial fibrillation and had heart failure, which certainly could drive medication exposure. It's a little bit hard to tell if some of these folks were getting treatment actually for their AFib with an IV beta blocker or an IV calcium channel blocker rather than for their hypertension. They also didn't look at differences across classes used for treatment, though I think that's nitpicking a little bit. What I think is a little bit more concerning is I mentioned that the way this study was structured was they focused just on the highest blood pressure during hospitalization. It's kind of hard, like clinically, to think about how we would interpret that. So one patient might have 10 blood pressure recordings of 160, and then on the 11th recording, it's 170, and a team decides to treat them. And another person might just have a single elevated recording of 170, and I could imagine those folks might be less likely to be treated, but also might be less likely to have end organ damage like acute kidney injury. And so focusing just on an individual reading certainly, I think, is a challenge to apply clinically, particularly because if I'm on the wards, I don't actually know if a patient's blood pressure of 170 is going to be their highest during hospitalization. The study design risks this kind of peering into the future, which is something that we can't do on our own in the real world. So we've been asking, again, can we try to address this issue using existing data, but in a way that gets around some of the risks of this one prior study that exists in the literature? And really, we've been influenced by the work of Miguel Hernan, who's a statistician at the Harvard School of Public Health, who's been one of the leaders in thinking about causal inference, and particularly this idea of target trial emulation. So how do you design observational studies that are meant to emulate that randomized trial that you would do if you had the ability to do a randomized trial? And I'll pause and say, if anybody has $25 million and wants to do the large randomized trial, I'm more than happy to abandon these observational studies and do that trial. I just haven't been able to find the spare change in my couch quite yet. But I, again, will admit that an RCT would be best if possible. So what we've thought through is, again, focusing on older adults in the VA who are hospitalized for common, not heart, not hypertensive crisis conditions. How do we design like that perfect RCT? And the perfect RCT would probably be that you would randomize people the moment they walked in the hospital. Some people we're going to treat intensively if they have any high blood pressures. Other people we're not going to mess around with their blood pressures as long as there's no sign of end organ damage. That's hard to do observationally because you still have to rely on the fact that there's treatment heterogeneity in the real world. So how we structure this is thinking about the first 48 hours of hospitalization as kind of an exposure or recruitment period. So patients can enter our cohort if they have multiple high blood pressures when they first come into the hospital. And we determine treatment by whether or not they get intensive treatment in that first 48 hours. So do they get IV blood pressure meds? Do they get new pills that they weren't taken at home? And then we look at outcomes for the rest of the hospitalization. So, if somebody has a stroke on hour 44, they don't fall into our cohort. That's still, treatment accrual time. And we focus on outcomes only once we've hit that 48-hour mark. Focusing again on, I think, the outcomes that will be most important to patients in the short term. Do they truly have a cardiac event or a stroke? And then do they have lab changes like signs of acute kidney injury or BNP elevation? The key assumption here is that if we start to treat patients intensively in the first 48 hours of hospitalization, we're going to continue that practice pattern through the full course of hospitalization, which may or may not be entirely true, but I think has some face validity in that typically, once we stick to a treatment pattern, we tend to persist with it, at least across an individual physician. This is ongoing work, so I don't have kind of full results to share with you, but I'll give you some sneak peeks. We actually find in our VA studies that about 2/3 of patients in the VA hospital actually meet entry criteria. Again, I think pointing to how important this is as just like a common clinical scenario. And so adequate sample size of truly hundreds of thousands of patients who have high blood pressure in the first 2 days of hospitalization, the vast majority of whom actually have well-controlled home blood pressure, so blood pressures less than 140 before coming into the hospital. We found that about 1/3 of patients in the first 2 days receive more intensive blood pressure medicines. Most of this is new pill medicines, but not a small proportion receive intravenous meds as well. And I think perhaps most interestingly, the VA is about 120, 130 hospitals, and we see really wide practice variation between different hospitals, despite the fact that they are all taking care of very similar patient populations and are in some ways like a very integrated network. Some hospitals are using IV meds in nearly 1/3 of patients. Others are very, very uncommonly using IV medications. And I won't show you clinical outcomes because these analyses are somewhat complicated to structure and are still ongoing, but hopefully you'll get to read them in a widely read journal soon. But I will kind of share the spoiler alert that the study findings we have, despite this different observational study design, are very similar to the Cleveland Clinic in that we're not seeing signs of benefit from intensive blood pressure treatment elevation. So this brings us back to this question, should we acutely be treating high inpatient blood pressures? And obviously the most important steps are what we teach our trainees, which are, is the high blood pressure real? And do patients have signs of end organ damage? And I think these are first principles, but still something we probably don't revisit as often as we should. I think there's really a lack of data to support the use of IV antihypertensives for asymptomatic inpatient blood pressure. And there's certainly this concern of overcorrection, and that's may risk possible harm. And I like to reflect back on outpatient practice and this idea that we never really view treating outpatient blood pressures when they're high as something we can just do with PRN medications. Like I don't ever see someone in clinic and say, just take 1 dose of amlodipine and, we'll see you in 3 months. And so it's odd. It's always been odd to me that this is a practice that we often use in the inpatient setting. But it leaves open this door of, sure, maybe we shouldn't be treating stuff to have a benefit right now, but high blood pressure is still not a good thing. Maybe we should be using hospitalization as a time to intensify home medicines. If someone truly has high blood pressure, why not get them on a path towards better care while they're in the hospital? And this brings me to kind of the last third of the talk. So should we be using hospitalization as a time to intensify outpatient regimens? So there's two sides, I think, to every story. And I think this makes for a nice debate. One view I've heard, and I'll say it's often been championed to me by my cardiology and nephrology colleagues, and I'm happy to debate this more with you all, is this idea of hospitalization as an opportune time to set people on the path towards better long-term blood pressure control. We certainly have more time with patients and we have more resources. Often we have in-house pharmacists or dietitians or other folks to kind of have support that we might not have in a brief office visit. And we have many, many more numbers. We have, not just like one blood pressure reading every few months, but we have multiple a day. The contrasting viewpoint is this concern that adjusting medicines while folks are in the hospital for totally different reasons may actually cause more harm than benefit. Perhaps we should be focusing on the reason for hospitalization as a priority and not really focusing on chronic diseases that aren't related to why folks are in the hospital. Often this viewpoint's been espoused to me by my geriatrics colleagues and primary care docs as well, who have concerns about the post-discharge period being a high-risk time where folks, are often getting multiple new medicines, and so adding kind of more complexity there could risk confusion and problems related to meds, as well as this concern about overtreatment if we're treating people who are only transiently high. So we've had a couple, I think, impactful publications in this space to have tried to ask, what happens when folks are sent home on more intensive blood pressure medicines after hospitalization? And so I alluded to this BMJ study. I'm going to talk about it and a subsequent JAMA internal medicine study that were basically, all part of the same cohort that asked, how often do we send people home on new medicine? So again, not focusing on what happens in the hospital so much as what happens at discharge, and then what happens to these patients after they return home on more intensive blood pressure medicines. All of this work is focused in the National Veterans Affairs Health System in the US. And we really focused on folks in the hospital for three conditions that we thought were common and weren't typically associated with reasons that we would need to adjust their blood pressure medicines. So we looked at pneumonia, we looked at venous thromboembolisms, and we looked at hospitalizations for UTIs. And in the initial study, our data was a little older in 2011 to 2013, and the newer studies are a few more years more recent. First, we examined how often this happens, and we looked at the predictors of who gets sent home on intensified antihypertensives. And then similar to the Cleveland Clinic study I described before, we used propensity matching methods to compare patients who received and did not receive antihypertensive intensifications at discharge. And just to kind of make sure if folks aren't familiar with propensity match methods, the idea here is that you take kind of any covariate you can measure and you throw it into a pot to try to predict not an outcome, not a clinical outcome, but try to predict the propensity of being treated. And so some patients, like perhaps the 75-year-old who's had 7 heart attacks and also has CKD and also has strokes, probably has an extremely high propensity to be treated. The patient who's 22 in the hospital for a broken leg, who's never had a heart condition at all, is probably, very low propensity to be treated. And so you try to match patients by their propensity, not that they look like the exact same patient, but that their overall propensity to be treated are similar, whether or not they were treated. And it's a method to try to, compare apples to apples instead of apples to oranges. Like I said, with the big limitation being the risk that if you can't measure part of what could be driving a treatment decision, then you may have residual confounding. And so in our case, we used the fact that we had access to inpatient and outpatient VA pharmacy data to identify admission and discharge medicines. And we called an intensification as either being started on a new medicine that patients were sent home with, or having a substantial dose increase of an existing antihypertensive. And then we looked at a couple different outcomes. We looked at readmissions within 30 days, because this is a big health policy driver that is often thought of kind of one driver of care. We looked at serious adverse events, and these were modeled off the SPRINT and ACCORD clinical trials. So we looked at composites of ED visits and hospitalizations for falls, for syncope, for electrolyte abnormalities, and for acute kidney injury, as well as cardiovascular events. And again, this was modeled after SPRINT, thinking about ED visits and hospitalizations for acute coronary syndrome, angina, stroke, heart failure. And we focused on a short timeline of 30 days for serious adverse events and a longer timeline of 1 year for cardiovascular events. And then lastly, we looked at what actually happens just to patients' outpatient blood pressure. It's a secondary marker, but it's still a good sign of whether or not we're having a treatment effect by intensifying patients' blood pressure medicines. And we were able to not just study what happened to patients in the VA, but because we were focused on older adults, we really had complete capture of whether or not they were hospitalized in the VA or another hospital in the US. We couldn't track people across international boundaries, but we could track them pretty much anywhere they might get their care in the United States. And what we found was about 1 in 7 of these patients who were in the hospital for non-cardiac conditions got sent home with intensified blood pressure medicines. And this was really heavily driven by what their in-house blood pressures were. This is kind of a complicated table, but the first thing I'll show you is just the proportion of patients sent home on intensified medicines really varied with what their outpatient blood pressure was. If you had good control blood pressure, about 11% of folks were sent home on intensifications. If you had very high blood pressures above 160s at home, almost a third of patients were sent home with intensified medicines. But this was even more strongly driven by their inpatient blood pressure recordings. If you had normal blood pressures in the hospital, you were a relatively small proportion of folks were sent home on intensified treatment, but nearly half of patients who had blood pressures in the 160s and 180s and above were sent home with more blood pressure medication. And in these adjusted models, it was really inpatient blood pressure that was the strongest driver, with odds ratios of 3.5 to 7.5 for severely elevated blood pressure. It's really, people are responding clinically to these high blood pressures when they're deciding about outpatient treatment decisions. We wanted to ask whether this was also driven by comorbidities that we might expect to influence treatment decisions. So if you had chronic kidney disease, if you had heart failure, if you had history of heart attacks, were you more likely to get these blood pressure medicines? And somewhat surprisingly, we didn't find significant differences based on existing comorbidities, either ones that would be associated with more likelihood to benefit, like pre-existing renal and cardiovascular and cerebrovascular disease. We also didn't find much difference across conditions that would likely make folks have less likelihood to benefit. So folks with limited life expectancy or with dementia or with malignancy really didn't have lower rates of treatment intensification. With metastatic malignancy, it was a low sample size, so we probably do see differences there, but it was not statistically significant in this study. And then Cleveland Clinic has kind of replicated these findings in a younger cohort and found similarly, they found about 1 in 10 patients were sent home on intensified blood pressure medicines. So our next step was to look at clinical outcomes. And like I said, we used propensity scores. We had about 4,000 patients, 2,000 in each arm who were matched. And as a VA population, again, this was a very highly male older adult population. So the mean age was mid-70s, about 92, 93% were male. And the racial balance was somewhat reflective of the US, slightly more Black patients than we would see in the general US population. At home, folks tended to run in the upper 130s as a mean. So about half the population was uncontrolled blood pressure, and about half the population was controlled at home. And issues like polypharmacy and frequent hospitalizations were very common, as was pre-existing cardiovascular disease. These were folks whose length of stay was about a week on average, and folks who had baseline kind of mild stage 1, stage 2 CKD. So what we found was that being sent home with intensified blood pressure medicines was actually associated with an increased risk, a higher hazard ratio of readmission at 30 days, with about 21% of folks receiving intensifications being rehospitalized versus 18% of folks not receiving antihypertensives. We also found an increased risk of serious adverse events. So again, acute kidney injury, syncope, electrolyte abnormalities amongst patients who received intensified blood pressure medicines. And a not quite significant, but somewhat opposite direction that you would expect signal of possible harm in terms of cardiovascular events. So we actually saw more cardiovascular events at 1 year amongst patients who received intensified blood pressure medicines, opposite of what you might expect, given that generally we think of treating blood pressure as something that prevents cardiovascular events. And we stratified this by baseline blood pressure control as well. And what we found was that these signals of harm were really driven by patients who at home had well-controlled blood pressure. So again, thinking through this may really be seeing signals of harm amongst folks who were over-treating because they actually were doing okay in terms of blood pressure at home. That being said, the patients with high blood pressure at home, we also didn't see benefit. We didn't necessarily see statistically significant harms in this group, but we weren't seeing cardiovascular risk reduction either. And then when we looked at outpatient blood pressures at 1 year, what we found were in these matched analyses, at baseline, at discharge, folks had a blood pressure at average just below 140. And a year from discharge, we saw a little bit of regression to the mean. So both groups dropped to about 134 on average. But what this tells us is there was really no difference at 1 year in blood pressure between the two groups, which again, counterintuitive, you'd think starting patients on blood pressure medicines would lead to blood pressure changes in the long term. And we'll talk in just a second about what this might indicate. Again, the Cleveland Clinic's largely kind of replicated these findings and focusing on a younger population and a more mixed population when it comes to male-female balance. And so I want to pause here and say that despite these findings, I'm not advocating that we shouldn't be treating blood pressure by any means. I think as has been espoused, at least by the US Surgeon General, it's actually kind of a national priority that we focus on hypertension as really a driver of not only preventable harms, but also inequitable preventable harms. And at least in the US, what we've seen more recently is actually a worsening in our population level control of blood pressure. And so as much as I may be now preaching that we aren't seeing benefit from doing this in the inpatient setting, this doesn't mean we shouldn't be thinking about how to do hypertension control better. I think it's important to think about why might we be seeing a lack of benefit. So blood pressure control is good. Why are patients not benefiting? Certainly one reason that I've talked about ad nauseum is that we may be treating patients who are actually normotensive at home. Another one I think is important is that we're sending people home on these blood pressure medicines. That doesn't mean that they continue on them or take them for a long enough time to benefit. And then a third one is, hospitalized older adults, hospitalized patients are often a very sick, very frail group. And so making treatment decisions in patients who may actually have limited time to benefit is a very different, set of clinical scenarios than making clinic treatment decisions on a healthy 50-year-old person in your office. And so focusing on the persistence question, there's been prior studies that suggest even in folks hospitalized for an acute myocardial infarction who we give free medicines to, we don't see great adherence. There's a really nice randomized trial from Nitish Chowdhury that looked at this in the New England Journal a few years back. And so thinking about persistence to medicines that we're starting that have nothing to do with hospitalization, you might wonder, is part of the problem here that people simply aren't sticking to the medicines we send them home on? And so we've looked at this in the same cohort I've described, and this is a graph looking at the rates of persistence over time after discharge from the hospital. And what you see in the different colored lines in gray and in red are folks who refilled a continued home medicine or had a decrease in their dose. And then in green and in blue, respectively, you see folks who had an increased dose of their blood pressure medicines at discharge or folks who were started on a new blood pressure medicine. And all groups have a pretty strong persistence drop-off by the end of the year. I mean, we see declines in use of nearly 40% amongst patients who were continued. But this is more pronounced amongst folks starting on new medicines. And those strong drop-offs you see at 30 days and 90 days are really reflecting the fact that these are folks who got one refill when they left the hospital and then never filled the medicine again. And the 90-day one is in part because the VA health system tends to do a lot of 90-day prescriptions. So really both of those lines are suggesting that a lot of this is primary non-persistence. It's folks who simply were started on it and then stopped it. And what we can't tell you is how much of this was the patient making a decision to stop the medicine or their outpatient doctors saying, hey, you don't need that. But it's certainly suggestive that we may not be targeting a population ready to benefit in many cases. And then finally, treating patients with limited time to benefit, I think, is something we probably don't think about enough. There's been really nice work from Sei Lee, a geriatrician at UCSF, talking about this issue of lag time to benefit when it comes to prevention decisions for older adults. And what that really is thinking about is when you think of a randomized trial like SPRINT, what is the time at which you actually see divergence in curves when it comes to benefit? And Sei's done a number of studies in different prevention treatment decisions, osteoporosis, starting lipid load therapies, and starting antihypertensives that suggest that time to benefit can really differ. And for antihypertensive management, it's really this thought that it takes 6-8 months, which is much quicker than many other preventative decisions, but it's still a pronounced enough time to truly have cardiovascular benefit even in the outpatient setting. So they found that it took about 8 months to prevent one major adverse cardiovascular event for every 100 persons treated, and have used that to kind of argue that if you're concerned about limited life expectancy, that patients may not live for 6 months or for a year, that those really may not be the patients to think about intensifying treatment for, even if they're high risk from a cardiovascular standpoint. So where do we go from here? I think rethinking our priors is important. This distinction between blood pressure as a vital sign, which is sometimes how we think of it in the hospital when we're thinking about hypotension, versus blood pressure as a chronic disease, is unfortunately something that I think often clouds our conversations. I do think there's patients who are likely to benefit from intensive blood pressure treatment interventions. The issue has been, how do we identify them? And this may be different in different health systems. You know, if you're able to look at home blood pressures and if you're able to have good communication with outpatient doctors, these may be the folks where there may be an opportunity here, versus folks who aren't connected with outpatient care or whom you don't know what their home blood pressure control is, maybe much more high-risk populations. There's certainly some research necessary here. We've focused on observational research around trying to understand, can we predict who runs high, both in the hospital and in the clinic? So I like to term this idea, how strong is the hospitalist white coat effect, much in the same vein that we think about the clinic white coat effect between home and clinic blood pressures. It would be great to have RCTs that look at more versus less intensive inpatient treatments. There have been these sorts of studies with diabetes control in the hospital, like the NICE Sugar trial and others, but we really haven't seen a lot of interest in conducting these studies in the inpatient setting. I think they are methodologically pretty complicated. More perhaps promising would be the idea of trying to look at what happens in intensifying blood pressure treatments in groups with the highest likelihood to benefit. So could we target those groups that might benefit, as opposed to just studying current practice, which doesn't seem to be doing a good job of targeting. And then what we've been focused on is developing pragmatic clinician-focused interventions. So can we teach inpatient clinicians to have a different framework for making these decisions? And can we also provide them with the data they need at the point of care, so information like home blood pressure medicines or home blood pressure readings, to individualize treatment decisions, to try to help folks not just say, I'm going to make a treatment decision because the blood pressure is 180, but to have a little bit of a fuller context of outpatient patient information when they're making an inpatient decision. And then I'll skip through this because we started a little bit late, but I also think there's important issues here when it comes to education, and Charlie Ray and I have put together this kind of 2-page primer that I think is great to use with med students and trainees that kind of goes through these principles of gathering data, contextualizing patients, treading lightly when making treatment decisions, and partnering with patients, which really tries to kind of distill this idea of, while there may be times to make treatment decisions, if you do that, you really want to kind of make it as not a off the cuff, oh, the blood pressure's been running high decision, but one that is fully understood by your patient and is done with all the information necessary to make a correct treatment decision. And in cases when it doesn't feel like the optimal time to make a treatment decision, really thinking less about prescribing and more about communicating to outpatient docs, to patients, to family members about high blood pressure in the hospital being something that really needs to be followed up on rather than something that needs to be treated right then and there. And I'll conclude by saying, you know, we've talked about blood pressure, we'll keep talking about blood pressure, but it's not only a blood pressure issue. We've looked at this in diabetes and found very similar sets of findings. And I think hypertension and diabetes are probably the two most common issues that in the hospital just get managed in a way that is not always evidence-based because it's reflecting outpatient treatment patterns, not the fact that inpatient individuals are just in a very different health space. But there's plenty to be done, I think, in both fields, particularly for higher risk populations. And with that, I'll just again acknowledge that we've had a lot of funding from different nonprofit groups, and that there's been a lot of folks on these teams, particularly from UCSF and from Beth Israel, both subspecialists, inpatient docs and outpatient docs. And so I'd be more than happy to kind of talk through any nuances to this. I really appreciate your time, and I'll try to exit out of the picture if I can.
Thank you. Thanks, Tim, for that wonderful overview. I think that's you have a huge body of research that you have done in this area. And I know there are some internists also in the audience, so feel free to raise your hand if you had any questions. In Canada, actually, we are in a very similar position with blood pressure control, with a decrease in blood pressure control, even if we use the threshold of 140s. And the similar sort of fragmentation, because all the primary care is, I don't know what is going on there. They're not in the same EHR. Moving on, I think Brendan has a question. Go ahead, Brendan.
Thanks, Tim. That was an excellent presentation, and I really completely agree with your focus on different goals in the inpatient and the outpatient setting. One thing that I've wondered for quite some time and would like to get your opinion on is we used to define hypertensive emergencies using mean arterial pressure. And you made the very valid point that we're concerned about blood pressure in hospital due to risk of organ hypoperfusion and arguably acute organ hyperperfusion. The intensivists all buy into the mean arterial pressure for organ hypoperfusion. And I really think that we should be looking at mean arterial pressures in hospital if we're thinking of treating a hypertensive urgency. As for example, a pressure of 180 over 60, which some residents might be tempted to treat as a hypertensive urgency, has the same mean arterial pressure as a 140 over 80. And I think that perhaps the focus on treating isolated systolic hypertension in the elderly, which came about in the 1990s, at the same time, that kind of shifted the focus from mean arterial pressure and kind of understanding the physiology of organ perfusion towards systolic blood pressure targets, which, while validated in outpatient settings, perhaps aren't in the inpatient setting. Are you aware of any attempts to look at mean arterial pressures as outcomes for acute cardiovascular events in hospital? Because it seems that most of the literature is looking at systolics.
Yeah, that's a great point. I don't even know if there's great literature that I'm aware of that has even looked at systolics or kind of any markers when it comes to truly like folks who come in with asymptomatic blood pressure elevations, and then what are the harms if they're just left alone. But I think it's something that is very studyable, even again with just looking back at observational data. I mean, the other thing that folks often bring up is this question of blood pressure variability, and whether not only is it that we're focusing on systolics when maybe mean arterial pressures would be better, but that we're focused on an isolated reading where if somebody's running 160 at every blood pressure recording, maybe that person is actually the lower risk person than the person who's alternating between 110 and 170 over time. And so I honestly think there's kind of like a big research opportunity to think about, better understanding that physiology. The challenge is, right, that hospitalized patients are just so heterogeneous. Like someone who's in the hospital for an elective knee replacement and somebody who's in the hospital for sepsis and is recovering, it is really hard to, I think, make broad generalizations across these different disease states when this is the secondary issue. And so that's where when we've thought about, what's the right question to ask to see, can we say, can we make better risk predictions just based on inpatient blood pressure measurement, whether it's mean arterial pressure or others, it's been hard to say what's the right population to say that in. Because if I say that in patients with pneumonia, I'm not sure I'm confident that that's the same in somebody there for an orthopedic procedure. It's super interesting, but I also think a little bit tricky. But I'd be happy to ponder studies. Like we have this, I think, pretty rich data set in the VA that we're just kind of sitting on, thinking about like how do we ask that question in the right way. And I imagine just knowing the high quality observational research that comes out of Ontario, y'all probably have somewhat similar opportunities as well.
Yeah, I'm not sure our inpatient blood pressures yet make it into that data set, and maybe Manish knows more about that. The other, of course, on MAP, it seems that our oscillometric blood pressure monitors actually, they measure a MAP or an envelope, and they convert that with algorithms into systolic and diastolic. So the MAP question might be important. Again, anyone else has any questions, feel free to raise their hand. But if I could ask something in the meanwhile, it's hard to ignore a number which is high, which is the basis of whatever happens in the hospital, and we keep telling our trainees, when the nurse pages, you don't do anything. But what kind of nudges? You mentioned at the end there's about physician education and putting people, making them easy to ignore and inertia. What kind of interventions do you think have been useful or have been studied?
Yeah, so I referenced early on in the talk this quality improvement initiative at UCSF, and I think the nice thing about the way they did that study was, if you simply focus on resident or med student education or even like hospitalist education, you're exactly right. You try to teach people not to respond to something, but if you're paged at 2 a.m. in the morning about a blood pressure of 170, like it's hard to not respond, even if it's out of self-interest of not wanting to get paged again. And so what I like about the UCSF study is that they actually really focused heavily on nursing education, and this idea that part of the culture change was not just shifting clinician response, but shifting how we think about responding or even, measuring, like the goals of measuring blood pressure. So this idea for nurses that if somebody is sleeping soundly and you measure a blood pressure and it's 160, don't page anyone, leave them alone like they are sleeping. If somebody is there, uncomfortable, acting unusual, like all of this, again, this idea of going back to symptoms or not, and even not necessarily hypertensive emergency symptoms, but just straight up like clinical status sorts of symptoms, I think is part of what we need to go back to. The other body of work that's not blood pressure specific, but I think is really relevant is, the set of work from hospital medicine folks that have looked at trying to not check vital signs as often in stable patients, and particularly this idea of not checking people's vitals in the middle of the night, trying to let people have a good night's rest and all of that. And if you think of, it's hard to not respond to a high number, the best way to avoid it is to have fewer numbers if we don't need them. And obviously that's different when folks are in the first 48 hours of hospitalization and perhaps unstable, but for folks who are kind of, on the mend, I think the more that we can think about, changing our inputs if we're not actually hoping to make decisions based on them, I think it's actually a more promising nudge. The best nudge is to remove the nudge altogether, I guess.
Yeah, that does make a lot of sense. I think we had a pilot project, I'm not sure it's still going on, in the geriatric unit where they did that, right? Like at night, shut down the lights, no vital signs, nothing, let them sleep in peace at night. If there are no other questions, and I guess, we are just over time, I would like to thank again Dr. Anderson for virtually coming to Ottawa and presenting to us on inpatient hypertension. Feel free to tweet at him and or email him with any questions as well. One day, I hope we'll be able to invite you in person here to come to our beautiful city.
I would love to. It's only a seven-hour drive. That's not bad at all. But no, thank you all so much for having me. And certainly, I'm always hungry to think about new research ideas and things like that. So always happy to reach out and chat.